Please interrupt me if I speak too quickly or not loud enough. This is always an issue. So I'm Maude Martinho Grueber. I'm very happy to talk to you about diagnostic workup regarding food intolerances. I'm actually a gastroenterologist in Hôpital de la Tour with a special focus in nutrition and mostly malnutrition and IBD, but I have also a little bit of experience in food intolerances, and I hope we can deep dive in that today. So why are adverse reactions to food actually important? Because 20 to 35% of the Western population have adverse reactions to food, and only actually 3.6% of the population have a well-documented food allergy or intolerance. And these unspecified reactions will often cause long-term dietary restrictions, leading to a worse quality of life, eating disorders, and probably also dysbiosis. What kind of adverse reactions do we have? When we think about adverse reactions, we think sometimes of allergies, sometimes metabolic disorder, but there are all kinds of adverse reactions to food that you can see here. I would not talk about each of them right now because we will talk about a few afterwards. Most patients with functional GI disorders report symptoms that they perceive as food-related, and in some cases, a dietary restriction will improve their symptoms, even though they don't have food intolerance that is really confirmed. Food intolerance is also sadly linked to a decline in quality of life and also anxiety and depression. And like I said before, risk of dietary restrictions and all sorts of complications. I just want to do a small minute about allergic reactions, because even though we are gastroenterologists, and this part is not really therapied by us, I just wanted to talk about it just 1 minute. So there are mostly big 8 food allergens. And when do we have to think about it? We need to think about it in case of immediate and reproducible onset. So in a few minutes of symptoms as cough, chest tightness, wheezing, hives, nausea, dermatitis, and angioedema. And what is a gastroenterology called? Mostly gastrointestinal symptom linked with that is actually vomiting and not diarrhea or abdominal pain. And in this situation, there are a few algorithms, but I think the best thing to do is to refer the patient to an allergologist to have the best tests done. And what I just wanted also to talk about is what kind of tests are not advised, because sometimes we see patients coming to our outpatient clinic with all sorts of tests and very, very concerned about what they see. And total serum IgE are actually not advised because they are insufficient in terms of sensitivity and specificity. And allergen-specific IgG or IgG4 are also not very adequate, since they actually detect an exposure and not an allergy. And some patients having actually allergy will have normal IgGs. There are also other uncommon food allergies. I will let you read them, but it's just also to point the importance to look a little bit ahead. What kinds of non-allergic or non-immunologic food reactions do we know? The first one I will talk about quite quickly also is a non-celiac or gluten wheat sensitivity. There was an international expert meeting in 2014 defining the diagnostic criteria for that. There are persistent intestinal and extraintestinal symptoms while on a gluten-containing diet. We first of all, of course, need to exclude celiac disease and wheat allergy with the written tests. We need to see an improvement of the symptoms after initiating a gluten-free diet for at least 6 weeks. And the last point is a little bit tricky because difficultly done in also the clinic situation. A gluten challenge using a double-blind randomized placebo-controlled trial should actually show a recurrence of symptoms. A growing problem with that is the self-diagnosis of this entity, because many patients will eliminate gluten-containing foods from their diet without undergoing any medical investigations, with the risk of undiagnosing celiac disease with an amount of 40% in certain patients. So it really is important to exclude them. And also this diagnosis is quite difficult to make because there can be an overlap with IBS, as you probably all know. And it is also important in the title, the name of this, the definition of this entity is non-celiac or non-gluten wheat sensitivity, because there are other proteins and other things in wheat that can actually give a reaction, as for example fructans or also central enzymes. And why is it important in today's discussion? Because a lot of IBS patients have food-related symptoms, and at the moment, these patients having food-related symptoms, the diagnosis of IBS is not different from the patient having the same symptoms but not food related. So of course we will use the Rome criteria, use a few normal routine clinical tests, and in case of alert signs, rule out other organic diseases through endoscopy or radiology. The next, in these patients, when we have the diagnosis of IBS, if we have a food-related GI symptoms, then we'll first of all exclude specific food inducing the symptoms, typically in this patient, but in most patients, for example, fiber, fatty food, spicy foods, and alcohol. And if the symptoms will persist, mostly also with bloating and flatulence, we'll maybe talk about, with the patient, we'll talk about doing other tests to evaluate the presence of lactose intolerance or carbohydrate, other carbohydrates malabsorption. And there we arrive to lactose intolerance. So lactose intolerance, as you know, is a clinical syndrome. So patients have abdominal pain, bloating, diarrhea after consuming lactose. But to talk about lactose intolerance, we really need to confirm also these symptoms with the lactose malabsorption through different kinds of tests. As you know, lactose intolerance, the prevalence is quite high, worldwide around 68%, with higher rates reported for genetic tests and hydrogen breast tests. And the lactose malabsorption is lower in Nordic countries and higher in Korean and Chinese patients. What is lactose intolerance? Lactose is a disaccharide and is normally broken into glucose and galactose by the lactase enzyme found in the small intestine. Lactose malabsorption, whether it is due to primary or secondary lactose deficiency, will lead to undigested lactose interacting with the intestinal microbiota. And this microbiota will produce short-chain fatty acids and gas. The gas will induce bloating, and the diarrhea can come or from lactose itself, like an osmotic diarrhea, and there is too much lactose for the microbiota to actually ferment it, or also from too much short fatty acids that cannot be reabsorbed. What are the causes? Most of the cases are linked to primary lactose deficiency or lactose non-persistence. Lactose deficiency is characterized by a gradual decline in lactase enzyme activity as individuals age. The decline most of the time begin during infancy, but can also arrive in adolescence or early adulthood. And in the Caucasian population, lactose persistence results from a gain of function mutation on chromosome 2, and this genetic mutation, as you know, is dominant. So lactose non-persistent is actually not really a disease, but rather a genetic wild type. Secondary lactase deficiency is linked to damage to the intestinal epithelium, and once the situation is cleared, patients will have again the lactose function. There are 5 tests of lactose digestion that are available, each of which investigates different aspects of the process and has specific advantages and disadvantages. As you can see, some of these tests will bring a lactose challenge and assess for the symptom of lactose intolerance, which is actually normally needed for the diagnosis. Lactose hydrogen breath test measures the expression of hydrogen in expiratory air after an oral challenge with a standard dose of lactose. As normally this hydrogen is not produced by our cells, it indicates contact of the sugar with the bacteria. And normally in the clinical practice, we use 20 to 25 grams. In the studies, we sometimes use more. And this is actually to show you that in patients having larger amounts, as used in epidemiological studies, you see that even healthy individuals can develop lactose malabsorption. And they actually tolerate the amount of lactose that you have in a normal diet. And the other point that is actually important here is that you see that IBS patients and healthy volunteers will have the same amount of malabsorption in both in the different situations, but you can see that the intolerance linked to this amount is actually much higher in IBS patients, making them probably more sensitive to the lactose intake. So for this reason, in our practice, in my practice, for me, the health breath test is a method of choice because reasonably reliable with also the digestive function and the patient's symptom. I sometimes use the lactose tests on endoscopic biopsies of the duodenum. If I have a situation when I need an endoscopy, I will often do it in case of bloating symptoms, discomfort. What is important is that actually this lactose intolerance is sometimes patchy, and it's important to take different biopsies. In the therapeutic options, I will let my colleague discuss about the diet impact. Of course, you can use lactose supplementation as tablets. And there were a few studies also evaluating the impact of prebiotics and also probiotics, because they can actually have an impact on the lactose tolerance. The prebiotics and the probiotics will change a little bit the microbiota, and we'll have more if we give, of course, bifidobacterium as probiotics, but some prebiotics, as for example, galacto-oligosaccharide, could increase the amount of bifidobacterium and induce actually a tolerance for that. The studies stayed quite small, and in my practice, I don't give prebiotics or probiotics to the patient, but I thought it was interesting to talk about it today. And one of the limitations of this treatment is that a minority of patients with lactose intolerance will actually report a satisfactory improvement in symptoms after treatment. What is funny is, I must say, in my practice, I wouldn't say a minority, but in the studies, they describe the minority. So maybe there is a small discrepancy there, but to what can it be actually linked? And it could probably be linked to the presence also of functional bowel disorders as IBS. And in this specific algorithm done from Benjamin Misselwitz, you see that in case of 2 weeks lactose exclusion without improvement, there is a proposition actually to try a FODMAP diet. So I think this is also important to know. What about fructose intolerance? It can be hereditary. In this case, it is mostly developed in the pediatric age with gastrointestinal symptoms and potentially lead to long-term organ damage. And I'm not going to talk too much about that. What about non-hereditary fructose intolerance? The literature describes a non-hereditary fructose intolerance caused by an insufficient uptake of fructose into enterocytes related to the amount of luminal fructose. Fructose absorption in the small intestine is actually lower than glucose absorption. You see all kinds of transporters, and the only transporter that transport fructose is actually GLUT5, and it is linked also to the glucose intake. So in the case of where you have too much fructose in comparison to the glucose, there is a risk of malabsorption, fermentation to the bacteria in the colon, and all what we talked about with lactose is actually true also in this situation. I will let also my colleague talk about that. And how do we diagnose this is fructose malabsorption. Fructose malabsorption is usually diagnosed by a hydrogen breath test, but, and this is a very big but, there's insufficient information regarding the frequency of incomplete absorption of fructose in the healthy population, with probably very big variations in the ability to absorb fructose in healthy adults, and also are probably linked to the quantity and the kind of solution used for fructose administration, and also the fact that we give fructose alone in these breath tests, and which is not the case in the normal diet. And this is why the utility of fructose hydrogen breath test is actually fully debated in the different guidelines. And also interestingly, in a recent randomized controlled trial, it was observed that despite the challenge of a relatively high dose of fructose administered to reduce the risk of false negative breath tests, 65% of patients with a normal fructose breath test actually improved with a fructose restricted diet. So probably the diagnosis there is not very, very good. Rather tests, so what are the options? What should we do with suspected fructose intolerance? We should rather test for fructose intolerance rather than fructose malabsorption, and probably directly do a trial of fructose reduced diet. And there is a necessity to develop different valid outcome measures to actually be able to evaluate the result of these trials. One is a carbohydrate perception questionnaire that we could probably use. And the objective of this is to reduce the amount of fructose intake in excess from glucose and co-intake of fructose and sorbitol, since it inhibits also the fructose intake. And probably as in the lactose intolerance, we should, in patients that do not respond, but probably even more in all patients in possible fructose intolerance, probably rather advised for a low FODMAP diet. There is also different possible enzymes that we can give. I personally don't use them so much, and also the evidence is not very high, so I'll just pass. And we have lactose malabsorption, fructose malabsorption, but also probably a sucrose malabsorption. It's a disaccharide of glucose and fructose. Personally, at the moment, we have the impressions that more and more patients with IBS probably could have functional sucralose genetic variant, but we are not able at the moment to really diagnose in the same way as fructose intolerance, this intolerance, only in the children where we can really find a special mutation. And in this situation, treat with a saccharosidase solution. What about sugar malabsorption and IBS? There is, in the different studies that I already showed you and will show you, there's not so much difference in the frequency of sugar malabsorption between IBS and healthy patients. But when we do the sugar challenge, it induces more symptoms in IBS patients, as I showed you in this study with lactose. And this is another study which shows the prevalence of fructose and lactose intolerance in the Rome 3 this time, but defined IBS, and also the percentage of patients on the inferior part that have functional gastrointestinal disorders with symptoms provoked actually by fructose or lactose breath testing. And least but not last, in IBS, of course, one of the treatment is the low FODMAP diet, which was found to be effective. Some recent studies show that it's probably more effective in IBS-D and IBS-M than in IBS-C. So the FODMAPs are short-chain carbohydrates that include a lot of different saccharides, monosaccharides, disaccharides, and poly and oligosaccharides. The way to do it, I will let my colleague explain it after that. And the risks of the low FODMAP diet, of course, is the consequences, and we can have nutritional consequences with deficiencies, constipation, eating disorders, or microbiota disorders. And that's why that the top-down approach could probably be changed to the bottom-up approach although at the moment it's not totally accepted. And this is my last diapositive for today. The future is probably rather food-related symptoms and food-related diet in IBS. A few devices are under research, and I hope one day we'll be able to use these to help us guide the patient. So I'm done.
Thank you very much, Maude, for giving a really nice overview on the diagnostic workup of food intolerances. And I personally do have a few questions, but we'll wait with those and collect those towards the end. It's now my pleasure to welcome Jelina Linder to give us her presentation on the dietary interventions in food intolerances and also in functional disorders. Jelina, thank you again for speaking today to us, and I look forward to your presentation.
Thank you so much, Daniel. I hope everyone can hear and see the presentation well. Otherwise, I'm also happy for input or signs if that's not the case.
Looks good, thank you.
Great. So I'm already happy for the workup in the other presentations, so I can really focus on the interventions, which I really like. First of all, I would like to explain my background and my disclosures. So I'm a trained dietitian specialized in gut health and microbiome. And as Daniel said, I was very lucky to be part of his team for the last 5 years and now go some other ways. So I'm currently working for 3 different companies. Today, I would like to focus, as already mentioned, on the low FODMAP diet and other exclusion diets like the low histamine diets. But as already mentioned, there are also some risks for these diets. I would also like to introduce you to the approach of the inclusion diets and the microbiome-friendly diet, and also to additional interventions we dietitians use in order to prove symptoms on a more holistic level for our clients. So what can we change with diet? When we change the diet, we have different approaches where we can also change the root causes of IBS, especially also the gut motility or visceral hypersensitivity. You might all be familiar with, and that's why I think it also is good to take the nutrition seriously, but also not too seriously, because of course we cannot have an influence on all the root causes with dietary interventions. For the exclusion diet, as already mentioned, the low FODMAP diet is the most important one, and it's defined as fermentable oligo, D, and monosaccharides and polyols. So these are all carbohydrates that are naturally present in certain foods, and they can have like various effects on the digestive tract. And yeah, the tolerance is not the same in all our IBS patients. And that's why it's important to assess the tolerance and also to see whether they can benefit from a low FODMAP diet or not. For the different groups of the FODMAPs, we can say that not all the groups are always important for all my clients. That's why I find it very important to assess well which foods may cause problems, or if, for example, a lactose intolerance is already clear or also excluded. So for the galactanes, which are here, we have especially the legumes, but also like oats, for example, that contain a lot of galactines. We have the fructines, where the wheat group is included, and also the really, really FODMAP-rich foods like onions and garlic. Of course, the lactose will cover the dairy products, and for the fructose, we mainly talk about fruit, but also vegetables like asparagus or tomatoes contain fructose, and it can cause problems when consumed in higher quantities. Fructose also sometimes is added, especially like to diet drinks or products. Not so much here in Switzerland, but also in other countries like the US, that's very common. And of course, in my practice, important to talk about. The polyol group is also a group that contains additives, so especially in chewing gum or in other mints. We have a lot of sorbitol as additional sweetener, but also in real food like sweet potato or avocado or cauliflower, they're also high in polyols. For the pathophysiology, I'm happy that this was already explained. We can also say that, for example, the fructose and the polyols, they are more prone to have an effect of the small intestine, whereas the oligosaccharides and the lactose, as mentioned, work more in the large intestine. Both can cause these symptoms like bloating, distension, flatulence. And what I find really important to explain as well is that the bloating and the distension often has an impact on the motility as well. And so it's always in my focus to improve my motility in this case. So we don't have this ping pong effect of first really bloated and high distension and no movement at all. And then at one moment it changes and goes to the other direction where people experience diarrhea. I would also like to talk about the histamine diet, which has been much more common in the last years. Histamine is an amine that's found in food, and the intolerance, I think it's also still quite a difficult topic to talk about in a scientific perspective. But what we see is this equilibrium of accumulated histamine in the body that can be actually triggered by an extra ingestion of histamine with food. And that, in my opinion, it's really important to consider histamine intake, whether if it's an intolerance or not, we can discuss about later. But to be aware that maybe too much histamine can also trigger the symptoms as well. When we do a low histamine diet, we not only avoid histamine-rich foods like fermented foods that have a lot of histamine inside, but also foods that contain similar amines like avocado, for example, that might use the same degradation enzymes as histamine and also can make the symptoms worse. We also avoid histamine liberators, which is like alcohol, for example, one really important point, because if the histamine is always released extensively in the mast cells, then of course the total amount of accumulated histamine can be a problem. And the big question is, what do we eliminate? So as already mentioned in the other presentation, it's really important to decide together with the clients what they think they could be reacting to, but also, of course, to take the diagnostics into consideration before choosing the foods that should be excluded. What we do then, we change it from a regular diet to the elimination diet for 4 to 6 weeks. Sometimes we can also start, as mentioned in the other presentation, with a bit more gentle approach to just take a few things out and change the main triggers, and then see how this feels like, how the symptoms change, and then go to a more strict elimination diet. Some people, though, they already tried a lot and they're quite impatient. So then it's, of course, also an option to go to the full elimination diet directly. After the elimination diet, which is, I feel, the more easy part, it goes to the testing phase, which can be very challenging and can also take a long time. So it's important to guide the clients through this phase, to have frequent meetings to see which foods were tolerated and which foods are not, and to really take some time there to figure it out completely. Also, a lot of people that want to stay on the elimination diet because of yeah, of course, they feel maybe much better, but I feel it's really important to also explain that, especially for the diversity, the testing phase is crucial, because otherwise they will stay on a very, very limited diet for a long time. Then, of course, hopefully we can see what is possible for an adjusted long-term diet. In this case here, I would like to present you, this was a woman, she was in her mid-ages, had family and job, kind of a high stress level, but as you can see, a very balanced and very healthy and a very fresh diet. She was starting the day with a muesli, she had some fruit as a snack, she had a salad for lunch and dinner together with the family, and also some dessert. So when I see this from a general dietitian perspective, I would say she's doing a lot of things right, but especially when it comes to IBS and functional disorders, if the diet is too healthy, this can also cause problems. And a lot of people are not aware, and they try to eat more healthy, and then they increase the fiber intake, they increase the FODMAP intake, and actually feel worse than before. I also often see that in people that switch to a vegan diet, for example, where they actually are completely unable to digest all these additional fibers. So in this case here, we were talking and decided to go on a low FODMAP diet. And the high FODMAP foods, we were just swapping for low FODMAP alternatives, like the lactose-free dairy products, different nuts, different oranges, like as fruit, and different vegetables and starchy components. It's also to be mentioned that the low FODMAP diet and the low histamine diet, they are actually quite difficult to combine, because whenever we choose another option, then they are high in histamine or high in FODMAP. So when I have clients that react to both parts, it's really important to guide them even better, because the food choice will be very limited. In a case two, this is a completely different picture. This was a person who already tried a lot and felt that she was intolerant to a lot of different foods. So she was staying with just a few foods she was still tolerating. She was also not having breakfast because she felt more sensitive in the morning, and the diet was not very different from day to day. So especially potatoes and rice were her main food sources. Sometimes some chicken, some carrots, also some like zucchini were included, but basically a kind of a, not very nutrient dense diet. Also, this client said that she was eating no sugar, no gluten, no lactose, no raw vegetables. So she had a lot of information from different sources she was following, but still experienced a lot of symptoms. And in this case, the question is like, what are we doing with these people? And in my opinion, these group of people are nowadays much more common than the ones that really need to eliminate and to go on a, for example, low FODMAP diet. So this is a good review. I like to show how the different elimination diets have an impact on the gut microbiome. And you see here the low FODMAP diet is associated with decrease in total bacteria abundance, which we don't want long-term. So the low FODMAP diet is also not a diet for long-term, which I find really important to mention to clients. And on the other side, I could dive into this paper much more. It's really interesting if you want to read it afterwards. But the conclusion was really that a Mediterranean diet is the best for having a high microbiome diversity, a lot of anti-inflammatory agents, and also a lot of short-chain fatty acids that stabilize the gut mucosa. So the inclusion interventions, they really focus on this part, where I try to guide and explain how this diet has an impact on the symptoms, but it's maybe not about having an intolerance, but rather a lack of fiber and nutrients. and then to start to include fiber-rich foods again. And there I often start with the low FODMAP options to be sure they don't experience a lot of bloating in the beginning, and also to switch some foods from time to time. Also in this section, as you see, I really incorporate more oligosaccharides, especially because they are really prebiotic and they can help to increase bifidobacteria that also help the gut health to improve. Also, I'm trying to implement a diet rich in phytonutrients and polyphenols. So the variety is also a topic in this case, not only how much fruit and vegetable people eat, but if they change in between different foods. I also make sure they have an adequate protein intake, which is a really, really common problem, not only in IBS patients, but in general population, I would say. We maybe introduce some probiotic foods. And of course, we have a look at excessive sugar intake, the healthy fats that should be included and the unhealthy fats to be reduced if necessary, and also to limit processed foods and food additives, as they can also influence the gut microbiome. And then in the additional interventions, this is not something clearly related to food, but from my experience, more and more important in our society. So I really often talk about mind-body approaches for people, also for stress reduction. Regarding the food, this means that we focus on chewing the food, eating slowly, and to avoid distraction during eating. So especially the phone or the TV or the newspaper they have during eating can already be a big change. First of all, also to feel hunger and satiety better, to eat slower, and digestion starts in the mouth. I mean, that's a really important point that people can experience with these interventions. Also, I work with breath work. So there are some studies, I did not mention them here, that also showed that diaphragmatic breathing in reflux can be helpful. And same is my experience just for really stressed people or people that feel they don't really have a break in between work and food. They can practice some breathwork exercises for 3 to 5 minutes to just also have an impact on the nervous system. Also, gentle movement is really important. So especially IBS patients that do a lot of high interval training or really long and intensive cardio training, I advise them to slow down a little bit and go to more gentle movements like yoga and walks and sports that are less adrenaline rich and can also have a benefit on the whole symptom complex. Then also one really important topic is the fear of food, especially in people that had these problems for a long time, that felt better with an elimination diet and that are hardly going back to a regular diet or a more diverse diet. It's talking about how to deal with invitations, how to deal with restaurants, days, or also holidays are a big topic for these people. So we focus on that, and we also focus on the control topic, where of course it's nice if you are able to control the symptoms, but it's not always very rationally explainable why the symptoms come in a certain moment, and that they are often also not only triggered by food. And this fear of symptoms, of course, can also be addressed by a psychologue, psychotherapists. I'm also really happy if my clients have this in combination, because probably, as you know, or mention, or also see in practice, that the stress level and the psychological part is also a really crucial topic in our clients. So these are the sources I used for the presentation, and I'm happy and curious about the discussion.
Thank you very much, Jelina. This was wonderful. So I invite everyone to post questions in the chat, or also to raise your hands, and then we'll hear your question live. And there's already one question into the chat, and I'll start with that. Daniela Gödel was asking, what do you do concretely with patients who are in your practice, in your ambulatory practice, and they ask you if it's still not gluten, but celiac has already been excluded. So I'll ask this first to Maude. So you have this patient, gluten stays a topic, celiac is not a topic. What do you do? Do you offer anything diagnostically, or what do you do with this patient? I think this is something that happens quite often.
I think like in all situations, we exclude alert signs, all these kind of things before deciding not to go to endoscopy. It depends also how we can say that it's excluded. I'm not going to go in this area, but it really has to be nicely excluded. And when we're sure, I think if we have allergic symptoms quite clearly, or not very clearly, I prefer personally to send the patient to an allergologist, and then I would tell him to do a 6-week gluten-free diet to see if it actually really improves or not, and try it again. And I think if it comes back, I'm not going to tell the patient just stop gluten and go back home and everything is fine. Because as we know, it's not absolutely the gluten's a problem, but probably maybe also the fructans or other things in the foods that also contain gluten. And maybe the quantity is more a problem of just the gluten itself. And in this situation, if the symptoms come back, I would rather send the patient to a dietitian and evaluate if maybe by reducing a little bit the quantity and also looking for maybe other intolerances linked to FODMAP, we can improve the situation.
Mm-hmm. Okay, Jelina, I think I can also give that question further on to you, because this also happens in your practice, right?
Yeah, exactly.
And they ask you, so what would your take on this be? Also, Maude at some point said that she would refer to the dietitian. So what would you do if you have this question?
I also really like to educate on the fructans, because gluten, everyone knows, oh, this can be a problem in diet, but not a lot of people know about the fructan concept and also other ingredients, for example, in wheat, like the gliadins that are always like people talk about. So what I try to do there is I like to do like a provocation with seitan. This is a meat replacement that is just like real gluten, like gluten chunks, but they don't contain any FODMAPs. And it's sometimes really easy to just take them, like say them, hey, you can try this. Do you feel really, really bad about it? Then the gluten, like we need to address that problem, even if there's no diagnosis or no explainable reason. But very often then they tolerate this well, and we can work more on the low FODMAP approach, or also on just like another like process of, for example, baking bread, where there is a longer dough resting time that can already help also to improve symptoms. And as said, yeah, the quantity is a big problem. So if people eat wheat-based products 2-3 times a day, it can already be really helpful to just go on a bit lower amount.
I think that's wonderful. I like that idea with the seitan, which is pure gluten, actually. Of course, we do have the placebo effect. Of course, we can't get rid of that. Not in Switzerland, I believe, but in Italy, they have these double-blind self-tests that you can do, where they have these little capsules which contain certain amounts of gluten and placebo, and you can test yourself. And that's probably the best test, I would say, if you ask for a test. The next best thing is probably your seitan idea. I really like that, because it's clean of the FODMAP component, right? So you're just dealing with that. So I think that's quite an elegant idea. I think another argument that has to be brought in, that a lot of people who reduce gluten reduce FODMAPs at the same time, and they do better because they reduce the FODMAPs and not the gluten, right? And I think this is a nice study an older study by Mrs. Pisickerski, who did exactly that. She looked at patients who said, I do a lot of better if I eat gluten-free. And then she actually put those patients on a FODMAP-free diet, and they were doing even better, right? So I think that a lot of the people that say, I can't take gluten, it's not a specific gluten effect, which in studies has been shown to be between, I think, 7 and 11%. So very low, but most of the time it's really not the gluten, but just the FODMAPs or the fructines, especially that Jon mentioned. We have another question from the audience. This is Paul. What is your impression, your experience with a micronutritionist expanding specialists advising weird things? So, okay, this is a typical Paul question because it's provocative, it has the word weird in it. Let's take cynical answers aside and let's answer his question. So what do you think about micronutrition in regards to patients with symptoms, and what's your take on that? Do you look at that? Do you explore it? And also, do you do something then interventionally? Maude, I'll start with you. Do you look at this?
Yes. I would rather say that when patients come with these advices, I rather try to think, did I maybe miss a new concept? Sometimes it can be also just interesting to look a little more in the things that they advise. But my impression is most of the times they advise things linked to studies on animals, on mice, and it's not, these studies weren't validated after on human beings. So of course, what I personally say to the patient, because sometimes they come and say, oh, I'm doing really good. I stopped that and that and that and that. And I say, okay, you're doing better. That's very nice. But first of all, I can't advise you to do that because I have no evidence to tell you to do it. And the second part is really, I personally work a lot with dietitians when I'm not sure if the patient is doing that right or not, and the risk of deficiencies, I directly send to the dietitian so that she can maybe find other ways of having the right amount of or what is needed. But I don't try to come in confrontation.
You point towards the evidence, but you send to the dietitian who then has to deal with it. So what does Jelina say? And then I'll ask also Aurora. She raised her hand, and she probably has an answer to this as well. So please, Jelina, and then afterwards I invite Aurora to give her comment on that.
Yeah, I think we need to be really careful, first of all, to like not destroy the relationship to our clients and to really offer guidance and explanations. I really like the concept of like priority, because there are so many options out there, and probably all of them help a little bit. But what I try is to really focus on the ones that might give us the highest benefit, like quickly, that we can prioritize. And there, of course, a low FODMAP diet or another intervention might be extremely important. Stress reduction in some people are even more important than the low FODMAP diet, I would say. And to try to do the education there. And then also to be open for like new things. I mean, there's so much going on in this field, and I would say I'm really trying to stay updated with everything, but it's nearly impossible with the diet, like all the dietary things about microbiome. And then if the first things we tried, they don't work, then to maybe like just say, okay, let's first focus on that, and then maybe we can have a look again a bit later on. And also like digging a bit more in research where these recommendations maybe might come from.
All right, so you stick to your proven concepts, you prioritize. I think that's a very nice concept. Probably also taking into account the patient's needs really, and then you may look at alternative things or more new things, or possibly also things which have less evidence currently, but may be interesting in the future. Aurora, would you comment, or do you have a question? You are muted right now.
I have first a question. Thank you, Maude, and thank you, Jelina, for your again. So first of all, I have a question for Maude, and this is in regards to histamine intolerance. Does she test in the all-day practice the histamine intolerance? If yes, how? And does she already have some experience with histamine reduced diet, histamine poor diet?
I will be completely honest with you, and the only times that I had a diagnosis of histamine intolerance was 5 years ago when I was working in Lausanne University Hospital in nutrition. In the meanwhile, I never had again such a case. I think it was really an amazing case. I hope I didn't miss them, but I don't see so much of them. And concerning the diet, as again, it was only with one patient. So for me, it worked quite well when we eliminated the high histamine component, and this is also what is mostly observed. Concerning the diagnosis, I think for me, when you have a histamine intolerance, you cannot be, when you have the symptoms of the histamine intolerance, you cannot be sure it's not an allergy. So for me, you really need to send the patient to an allergologist and make sure there is no allergy, because everything the patient describes is way too, I mean, everything that we've learned, it really gives you the impression the patient has an allergy. And then, of course, you can focus on certain, you can already think about other things like some medications can induce histamine intolerance. You can check, did the patient have a new therapy given? You can also check for it, but I would really do an allergologist workup.
So maybe Jelina, you can jump in, because I mean, we see this a lot more, I would say. And so I think, and you also quickly mentioned on the problem of people that report problems with histamine and FODMAPs, which obviously then results in a super restricted diet. And then you were talking about going the other way around, the inclusion diets. So what's your take on this? I think we see this quite a lot. What's your take, possibly diagnostically? Do you have a hint for us? But then how do you manage this in your practice?
Yeah, I'm currently working on a little guideline with the team of nutritionists specialized in food intolerances, and I will definitely also send it to you once it's finished. Michelle, who still works with you guys, is also in the team. And my opinion, like from not from evidence, but really also from like experience, is now like we need to divide into histamine intolerance, which is super clear with the exclusion diet, super clear in the testing phase, and more of a histamine sensitivity, which also might occur with hormonal changes in menopause, and also in the second phase of cycles, like premenopause, before the periods, in the PMS symptoms, also together with hypersensitivity in endometriosis patients. So I think the topic really is like, how does histamine mediate pain, and also has an impact on the whole nervous system, and what are the influences there? And there's very like little evidence on humans, more like preclinical studies that explore this much more now. And my approach really there is to limit oral histamine intake, to work with medication that might help, and yeah, also to just really educate people on being aware that it might change and it might not always be necessary. Like for it, some like weeks are maybe better, weeks are maybe worse, and then to adjust the amount of histamine regarding these phases.
So you don't look at allergies really, you think there is a clinical picture which is clear to you, then you do an exclusion, you look at the reaction of the patient. This is also diagnostic in your sense, right? And then you try to differentiate based on the responses. I mean, histamine is an important player. There's the oral tolerance concept by the group of Guy Buxtons from Leuven, right? Who looked at histamine, the histamine degradation, proximity to nerve cells, pain responses and that. I mean, there's no clinical test for that. I can say that, right? We don't have that yet. Whether it will come, not sure. I mean, it's a concept, obviously, that has to be proven. This was done in rectal biopsies, not the same as an oral. And maybe Lucas also has an input here because he's been in Leuven, so he's been Leuvenized a little bit. So maybe he can say something. And secondly, he may have another question or comment. Please, Lucas.
Yes, well, thank you, Jelina and Maude, for these great overviews. First, for the Guy Buxton story, I think this is a very interesting concept, the histamine. but I don't think we fully understand yet. So he's looking at endogenous histamine released by mast cells as an allergic reaction. I'm not sure how much histamine we take in orally is actually absorbed unchanged in the intestine. So I think there is a lot of work to do between endogenous and exogenous histamine and that role. There's also some work from McMaster showing that histamine or histidine-rich foods in a microbiome can lead to a higher histamine content in the lumen of the gut. So I think there's a lot of open questions, but certainly histamine can have nociceptive effects. Very difficult to do studies to give histamine to patients. So that's why also this is very uncharted territory. I wanted to thank you, Jelina, for your overview on the FODMAP diet. And I think one thing that we as gastroenterologists should take really seriously is that the patient selection, right? You had patient number 2, which is clear that this patient should not undergo an exclusion diet, but we see often patients that are on the verge of becoming case number 2. And a second thing that I think, so I think that's something we have to take responsibility for, selecting these cases and really addressing this issue. And then what I wonder is, because this is a really, it's a quite restrictive diet, and it requires specialized care and follow-up. And I get very angry when physicians just give the FODMAP brochure and close their eyes, which still happens much too often. So I wonder, is there in Switzerland like a union of FODMAP specialized dietitians, or is there some way we can recognize who is trained for this? I know in other countries this exists, but I think this would be something very helpful to know who is qualified and experienced in administering this.
I will, of course, share this list with you. I'm really glad you asked these questions. We have one specialist, Beatrice Schilling. She works in Baden, and she has a website which is called fodmap.ch. She does a lot of formation for dietitians. It's a great job, great knowledge. And she also has a list on her website where you can see all the dietitians that did her training. Me personally, I'm not on the list, for example, because I had the training at University Hospital. But there, of course, regarding the region you work with or the gastroenterologists work with, you get to know these specialists. And also the Swiss Association of Dietitians has a list on their website where you can see specialties. But it's a bit more generally like who's a registered dietitian and less focused on gastrointestinal disorders.
So if I may jump in, Lucas, this is something we may want to do for the SwissNGM page. We can ask, Beatrice Schilling, we can ask Jelina, and maybe that, I think that would be helpful if this is something which, deals with all of Switzerland, especially, if you go a little bit away from the big cities. Big cities, it's rather well known who does what. But I think this could be a service to society more, if we put this together. And so maybe let's explore this in the future. I think this is an interesting.
I'm really happy to provide also the list. We also did one recently for histamine intolerance. Of course, we can also share this one.
I think that would be excellent if we could put that.
Excellent.
Well, I allow myself to make just to open a discussion regarding the micronutrition. I think the histamine and the mast cell activation or dysfunction syndrome might be the field where the nutrition itself and the micronutrition might come together, because when we are talking about mast cell activation or dysfunction, which we do not have yet the classical diagnosis yet, but there are already guidelines on mast cell activation. They already talk about supplementing, for example, quercetin or omega-3 or copper or zinc and so on. So I think this is a field further to explore, and I think as Maude already told, I think we are maybe missing a concept and ignoring a concept which might be adjuvant and not only therapeutic but adjuvant to our patients. So maybe it would be an interesting thing to look upon the eminence-based medicine, where if we look into the metabolism of the histamine, we have a lot of explanation why some patients are intolerant, why some patients might be sensitive, because some of them are deficient in diamine oxidase, some of them have malabsorption, but we should differentiate between the patients where histamine has a local effect and the histamine which is circulating into the systemic blood, because these patients are different patients. We have one with a digestive symptoms, but we have also with those with systemic symptoms. And here we go actually into the internal medicine, functional medicine, maybe.
Yeah, absolutely. It's a super complex field. And I'm glad that the research is focusing on this, and there's more and more things coming. Lucas was saying this is also not easy to study. And there are some interesting concepts which came out in last years. And yeah, the elements of micronutrition in this, stabilizing, non-stabilizing, what is actually a deficiency that may be meaningful. I think this is a very interesting field to certainly pursue and see what the future brings. Absolutely. All right, this was very enlightening. Once again, we went over time because our discussion was lively, and I think that's wonderful, and I think nobody regrets that. So I would like to thank, first of all, our speakers, Maude and Jelina, for really, really well-balanced and great talks, and also for all of you asking your questions and being interested in these topics. Thank you, Lucas and Isabella in the background, for organizing this and pushing this webinar series. This was our 4th webinar series, which we started early this year, and it's been very, very interesting, I must say, and quite successful. And we'll follow this up in 2025. Lucas and me just said we will sit together during the SGG Congress and look at new dates for the coming year. I think our next one, Lucas, will be about functional dyspepsia, correct? I think we already...
That's correct, yes.
Said that. Perfect. So functional dyspepsia it will be. Again, we don't have a date yet, but we will inform you once we know all this. We've recorded this talk, and we'll have it available on our YouTube for the video site. We'll make it available at some point. And yeah, thank you from my side. Lucas, do you have anything to add?
No, stay tuned for next year's program. I hope we can push that out mid-October, beginning of November.
Wonderful. Perfect. Thank you all,
okay.
And have a lovely late summer evening.
Thank you. Bye.
Bye-bye.
Bye-bye.